Welcome to Sit and Stay, the podcast that breaks down the challenges of starting and maintaining a mental health practice into digestible chapters. Sit and Stay is presented by RipsyTech, an electronic health record company committed to addressing the mental health crisis in the United States.
Welcome back to the Sit and Stay podcast, brought to you by RipsyTech. I am one of your hosts, RipsyTech product manager Parker Anderson. As always, I'm joined by RipsyTech founder and CEO, Tom Tarshis. Hi, Tom.
Hey, Parker. I love that energy on the introduction. Good to see you.
Yeah, good to see you as well. No adjectives today. Thought I'd change it up. So for today's episode, we are carrying things forward from what we were talking about last time, which is evidence-based medicine. In particular, today we wanted to talk about evidence-based therapy treatments and hope to cover evidence-based prescribing methods next week. But just to start with this week, we've covered a lot about evidence-based medicine. Before we dive into evidence-based therapy, anything that you'd like to talk about or mention?
Yeah. I mean, I think, this topic by itself could probably be 100 podcast episodes. So I think we'll sort of, look at this as, a little bit of an overview, but single out some of the best researched therapy treatments, and you kind of see where the conversation goes. I think it could stay open to doing some much deeper dives on other, just this topic is huge in general. And Parker, as a quiz question for you, how many different,
I always get these wrong.
how many different therapies are there? How many different psychotherapy treatments are there?
49.
There are over 300.
Wow.
Different psychotherapy treatments. And that number's from a few years ago, and it's probably like 350 by now.
Goodness.
So there are a lot of psychotherapy treatments, I think, is the main, is the message to get across. So being able to do justice to it in a, kind of one podcast episode is difficult. It is very easy to drastically reduce that number when you get rid of all the different therapies that have zero or very little evidence. It drops down significantly lower to where we're really probably looking at 25 different therapies maximum that have some pretty good evidence for use for mental illness. But just this overwhelming number of different therapies that have been developed over the years is massive.
So when we talk about these therapy modalities, are we talking about things like cognitive behavioral therapy or eye movement desensitization? Ooh, is that right? EMDR. Correct me here.
Oh yeah, EMDR. You're correct. Eye movement desensitization. I think the R is response.
Okay. But so like those types of modalities we're talking about specifically.
It stands for reprocessing. So
okay.
Yeah. So I didn't have that in my knowledge base. But yeah, interpersonal psychotherapy, parent training, rational emotive therapy. The list can get high pretty quickly. But yeah, those are all different psychotherapy approaches.
All right, so then let's dive in a little bit. So, you mentioned that there are a lot that maybe don't have as strong of as a research backing. Let's talk about the ones that do. What are some of the most well-researched therapy modalities currently going on in mental health care right now?
Yeah, but let's talk first about anxiety and depression, which we know these are the top presenting complaints of people who go to therapy. Anxiety is as high as 1 in 3 to 1 in 4 kids at some point could use treatment, and adults 1 in 4 to 1 in 5. So anxiety is the number one presenting problem for anyone seeking mental health treatment. depression is after that for in adult clinics. In child clinics, we get behavior issues and ADHD coming in. But so if we're sticking with anxiety and depression, almost everyone knows CBT or that term or cognitive behavioral therapy, which by far has had the most studies completed, some very well-designed studies. It's been tested by multiple different groups for many years, and shows very robust findings for treating both depression and anxiety. And Parker, you're sort of a mental health person or mental health adjacent. You've been
Sure.
around mental health treatment for years. Do you know the main principle of cognitive behavioral therapy?
Are we talking about like the CBT triangle or mentalization?
There you go.
CBT triangle.
Okay, tell us about the CBT triangle.
Yeah, so the CBT triangle, I used to teach this in session, group sessions. It's been about 5 years though, so apologies if I botch this at all. So the main conceit of the CBT triangle is that you have your behaviors, your emotions, and your thoughts. And each of those things is on its own point of the triangle. And really you can think of the lines of the triangle as arrows that are kind of pointing to each point. So the main idea here is that your behaviors impact your thoughts and your feelings, and your thoughts impact your feelings and your behaviors, and your feelings impact your behaviors and your thoughts. They all, coexist with each other and impact each other on really an equal playing field. So what I recall the most from when we worked in session was, having people identify maybe a thought and identifying, the behavior that's usually associated with that thought or the feeling that's associated with that thought, and kind of going in this like cycle and seeing how that cycle really kind of manifests itself in a real world applicable situation that maybe one of the patients was struggling with.
Parker, that was such a textbook, well done definition. Probably better than I could have done myself. But yeah, that is sort of this basic principle. And it's very logical if you think about it. And that there's a lot of flexibility with cognitive behavioral therapy because you're able to target thoughts, feelings, and behaviors. It can be a fun, active therapy. The skill comes with, are you bringing that energy to your sessions and getting your patients to buy in and actually make the changes that you talk about? Knowing that for one person, it's easier for them to learn how to do deep breathing and some muscle relaxation, which are behaviors that help them relax in the moment or feel less stress. But for other people, that doesn't work at all, and they do better with correcting some of their thinking patterns about situations that they're in. So the therapist skill is in engaging patients, testing different changes along the triangle and seeing what works best for them, and reinforcing that so it becomes second nature to your patients. I think that there's and this is interesting in my own training. When I first was taught cognitive behavioral therapy, we had let me not be as harsh with my terminology, but the teacher who was teaching us was not great at teaching us the concepts of CBT. And it is probably my most common. I don't know if it's my favorite therapy to do right now, but I feel pretty skilled and pretty good at it. But initially it was taught to me so poorly that I really did not like this therapy at all. Yeah, we had a much better teacher for our psychodynamic therapy. And so because there was such a good teacher, when you're learning the therapies, you sort of get pulled to that. But it was later in my training when really I became very into the research around different treatments that, whoa, this is really the therapy to use for kids around a lot of things. And and then fortunately I had some very good teachers later in my child training that was helpful. But so all that being said, like this is our best research therapy. And, Parker, in the drug trials or medication trials, we always can compare pills to placebos, sugar pills. And we talked about this a little bit last week. If they're when they were doing these studies for CBT initially, how do you do a placebo therapy treatment? What are some of the options there?
Gosh, a placebo therapy. Well, my first thought was like no therapy, but I guess just talking. I don't know.
Good. Well, good. Yeah, I mean, you're sort of on target, right? So it's maybe not super ethical to quote do no therapy, but there is this study design with waitlist control group, where if you've got a lot of people who are trying to get into your study, and right, therapy is harder to do studies on because you need clinicians to deliver it. There's lots of reasons why it's harder. But it is ethical to say we're going to do 20 people for the first 6 months. The other 20 are going to be on the wait list. We're going to track how everyone's doing, including the people on the wait list. And then at the 6-month mark, we'll flip the groups, and then the wait list people will come in and the CBT people will follow up with them. So that can be a reasonable ethical way to do it. You can just send people into supportive therapy, which is just say you're going to go do talk therapy, where you're going to, and then the therapists are going to just kind of, how was your week? What happened? And be a sounding board for stuff that happened during the week. It can be tricky because it's hard sometimes to not jump into some suggestions or discussions about your thoughts, behaviors, or feelings that may have happened that week even if you're just doing supportive therapy. So in a lot of therapy studies, you should be recording some sessions and then having other outside experts watch them and make sure they're doing the therapy, if it's just supportive therapy, not overstepping into CBT, and if it's CBT, making sure they're following standard CBT principles. But it is a lot trickier to do some of these psychotherapy studies. It is on some level, because CBT is so well established now, if someone has a new therapy treatment for depression, for example, there have been good studies comparing interpersonal psychotherapy for depression versus CBT for depression. That's like a nice, clean, ethical way to do it. And then if the new treatment is the same or better as the CBT, you're feeling pretty good about that therapy.
So is talk therapy something that really has research backing it as something that's beneficial, or because if you're using it as like a as a control in this case, is that really to say that it's good but it's not great?
This is a really good question as well, Parker, and I think it's great to play devil's advocate on things like this. So we also have very good research showing that if at session number 4 with your therapist, you really like your therapist, that by itself, no matter what your diagnosis or whatever treatment you're doing, is a pretty good predictor of success or of symptom reduction. So there is this underlying bias or around how much of therapy is just this connection you have with your therapist versus actually following CBT principles or a different evidence-based therapy treatment. And so a lot of therapy that is done in this country still falls into that category of just talk therapy. And I think if you ask people getting therapy, or if you're a provider, just the other day I had a new teenage patient who had been doing therapy for over a year. And I said, do you know what type of therapy you're doing? And you may not know the answer to this. And they did not know the answer to that. And from the description, it sounded like it was just talk therapy. And sometimes when someone's been in therapy for 3 years and their symptoms are not any better, you kind of worry about resources and is that the right treatment, et cetera. But the issue, and tying this into other things we've talked about and why so many people do private practices, I do feel like some therapists who are great at rapport and engaging with people and charismatic tend to do very well at getting patients and not needing to deal with insurance companies and other headaches. And is that because they're very good at delivering evidence-based treatments that get their patients better, or is it just because they're charismatic and
Likeable.
Engaging and people like them? Yeah.
Interesting. Is there ever, and we're kind of going on a tangent here, but is there ever concern about the patient liking their therapist to the point where they don't want to open up because they're afraid of disappointing their therapist?
That's a great question. I don't know if it's around the opening up place, but there are lots of issues that come up with, well, it can make it harder for someone to be honest that they're not getting better.
Yeah.
If you're, you develop this pretty close relationship, and if you're seeing someone an hour a week weekly and sharing a lot of personal information, like that's a tight relationship, and it can often get to the point that your patients don't want to hurt your feelings by saying something's not working or they're not getting better, or they are better and don't need therapy anymore. So it is really important for therapists and clinicians to check in with their patients on all those aspects. It's a great reason why doing some regular evidence-based measures or questionnaires is a little easier for someone to answer than in person. But then, it is this other, there is, whether it's real or not, always a subconscious pull that if you've got an easy patient paying you, maybe you don't want them to get better because that helps your business. And I think we need to be aware of things like that.
And avoid them.
No, just be aware.
All right. So to put us back on track, what we've talked a lot about CBT. What are some other well-researched therapy modalities?
Yeah, I'll say, for another very, very solid, much better than any medication could possibly do is for children with behavior problems is parent training. And so it's actually not working with the child, but it's working with the parents on changing how they interact with their child. There's many different positive parenting therapies. And this is another one where the skill of the therapist or clinician is really important as well, because you could actually sign up, right? And Parker, you're going to be a new parent soon. So you might say, oh, let's do a positive parenting. Let's be on the ball. And let's do a positive parenting course so we know exactly what to do. And a lot of parents that come in will say they've done this course or did this group. But the issue is that parent training really works best with being very specific about the issues in the household. And sometimes you can learn these principles. A lot of them are common sense, like try not to yell at your kids because it teaches them to yell back. Like, try to have a regular bedtime. Again, it's a lot on a basic level. It's not very intense topics, but actually implementing them in different households with knowing what's going on with parents' work or their relationship or kids' school or other aspects. That's the skill and the challenge that you bring to that. But oftentimes, and we're always very clear about this, like there's not a medicine that's going to create great behavior change for a child without, asterisk autism or some genetic abnormalities, et cetera. Sometimes medications can be very helpful, but in general, it is parent work. And so that, since we work with a lot of parents, that's a great one that we do a lot. Just on this topic, I'd say the idea of, the only one diagnosis in, mental health asterisk, this may be controversial, that doesn't really respond great to therapy treatments is ADHD in kids.
Huh. Okay.
So if you've got a hyperactive, inattentive kid and you bring them in to your office each week, it's unlikely that any skill you could teach in your office is going to have a drastic impact on their academic improvement and functioning. And you can definitely work on things like strategies on sitting still. There's some techniques to help kids focus, like different repeated sounds at different times, etc. But whether or not that does more than doing nothing is questionable and controversial. And there's been several studies that have reinforced this.
So what would the approach be in that case? Is it medication to help, a combination of medication and therapy, or parent training? What's the gold standard, so to speak?
Yeah, I mean, in general, parent and teacher work around how to help the child succeed, along with medication, is probably what's going to be the highest chance of success rate. That being said, it is always better to not use medications if possible. So if you have a family come in and the kid has ADHD and they don't want to put their kid on medicine, that is totally fine and appropriate. And you can push hard on helping the classroom environment, helping the home environment, and getting things in place to try to reduce the impact of the ADHD symptoms. It's a good lead into sort of the, how do you choose the right treatment for your patient? It's not just, okay, meds plus parent training, that's the highest success rate, we're doing that. No, you have to think about, all of the other factors of the patient that you're treating, and let it be really a patient or caregiver decision, not what you want to do.
Yes, well said. I wanted to ask one more follow-up question before moving on, which was, what about, we're speaking of ADHD treatment for children as this thing that, highly involves the caregivers or the teachers to be, the not necessarily authority figures, but like, the role models, the adults in their life to be involved. What about the adults struggling with ADHD, or adults who find out that they have ADHD and never paid any attention to that as children? What's the standard there?
Yeah, no, it's similar with kids in that still medications tend to have more robust benefit, is what research shows. But there are a lot of things that you can still do as an adult to set yourself up for success when you have ADHD. And it can be around, it's changes in your work environment. It's changes in your habits around sleep. Can you add in exercise? There are a lot of different things that you can do in your life that we know have a positive effect on focus, concentration, and attention. And so it's working with the adults to see what's possible and what's not.
All right, well said. Okay, so let's talk about, how does a provider choose the best evidence-based therapy for a specific patient or, specific diagnosis?
Yeah, and I think the main thing here, as we've alluded to, is throwing out choices for patients. When you first meet a patient, you're not going to, even if you do a several session assessment like we do, it's a new relationship and there's only so much you can learn after a couple sessions. So as I mentioned last week, like cognitive behavioral therapy really requires some very good patient participation. So if you've got a new patient coming in who's depressed, and you know that cognitive behavioral therapy is going to have very good success if you can get the patient to engage, and initially they're like, yeah, let's do it. I'm all for it. And then after 2 weeks, they haven't been able to do any of their outside session CBT homework, then you know that this maybe isn't the right fit. And then, okay, hey, we noticed you've talked about a lot of relationship issues. There's this other therapy called interpersonal psychotherapy, which is our other evidence-based depression treatment. Why don't we try that? And that still does require a little outside work, but less than CBT. It's talking about relationships and how to change those. And then if that still fails because they can't do the little outside work required from that, you can keep jumping through other treatments. There's mentalization-based therapy you can go to for depression. You can go to psychodynamic psychotherapy, and then you could just even drop down to supportive psychotherapy. And there's a bunch of other therapies in there as well. But I think it's this process of, here's where the best evidence is. Is your patient up for it, and is it appropriate? Let's try it. And if it's failing, don't just keep pushing through it, but be ready to switch your treatment style.
Okay, so being cognizant of time, we were coming close to the end of the hour, so I'm kind of thinking about which questions I should or should not ask. Do you have time to go over the hour?
Yeah. Yes,
okay. So to follow up on, I actually want to skip a question, perhaps go back to it, but what does a provider do when there isn't strong evidence for a therapy that they find to be effective?
Yeah, and that's a great question, and I think this is, the bottom line is, as I've talked about and as I've shifted to after all these years in this field, is are your patients getting better or not? So it's almost less about the whole symptoms, or even, I shouldn't say the treatment you're doing is not important, but if you've found, and every therapist will tell you this, that you have patients that come in and sort of talk nonstop for the entire 45 minutes, and they say, thanks a lot, see you next week. And you maybe feel like you've done nothing except be a good listener, but they get drastically better. And so I think using some regularly spaced outcome measures, as well as good communication and being aware of how the functioning of your patient is, like, that's enough to sort of justify, following a path that's maybe not the standard. If you've skipped going through the top 3 most likely effective therapy treatments, and you're not even sure completely what you're doing, but if the patient's getting better, as long as you're kind of commenting on that and documenting it, then I think you're doing fine, right?
Okay, so so to speak, what's the phrase I'm looking for? Like, if it ain't broke, don't fix it, or why ruin a good thing, or like if it works, it works.
Yeah, no, I know what you're saying, and for some people are better suited at being able to just shift what happens in the session to feel like you're being helpful for the patient, even if you're not doing a kind of textbook singular therapy type, or if you're combining a couple of different therapies. I think there is this, I think it's less now, but there are people who will say, oh, I do eclectic therapy, which is not a real thing, but it's, I do my own style of therapy, pulling from my years of experience and maybe some different principles of treatment. Often, it just means the patients come in, and it's often just the talk therapy or supportive therapy. But again, if you're getting measures and patients are getting better, you're okay with that. I think it's frustrating to me when a patient comes in who's been doing years and years of therapy, and it's not really helpful. They don't know what type of therapy it is. And then when you reach out and talk to the provider, they don't really know what the therapy they're doing is either. And they're maybe not aware, or with a, 6 to 12 months of therapy should be enough to get positive findings.
Right.
And if you've gone over that amount without making significant changes to the style or what treatment you're doing, I don't think that's serving our patients well.
Okay, so let's pivot a little bit to talk about randomized control trials, and this is part of that research process of figuring out, is a therapy modality showing effectiveness. So we did talk a little bit about randomized control trials last week, but for anybody that missed it, what role does that play in establishing the effectiveness of a therapy?
Yeah, and the gold standard randomized control trials are around medications, and they're complicated on one level, but on another, it's very easy in general to hide or to get a placebo that looks the same as the regular pill, and the patients take it and they don't know what they're taking, and then when they go in for evaluation or appointments, the people rating them don't know what they're taking, and that's how you can get very good data on something working.
Okay.
If you think about
Oh, go ahead.
Yeah, if you think about therapy trials, there's not a placebo pill that's as clean for therapy trials. So
I see.
You talked about these different. You can be doing different treatments, or do a talk therapy treatment or waitlist control. I think the issue comes with sort of this process called blinding, where you want the people in the study, the people evaluating the people in the study, and then the people doing the statistics and reporting to not know which group got the treatment and which group was the control. Mm-hmm. So that's what people have worked hard to figure out how to do best with therapy studies. And that sort of it is hard to pull off.
Yeah, that's work.
You need independent. You need to get a big team, and you need to hide from these independent reviewers which treatment arm people are in who are tracking the progress or collecting other data. You need to kind of do your best to hide from the principal investigators of the study, the statisticians, and it's just a lot harder to do it cleanly with therapy research than with placebo and medication research.
And you're saying hide from, in the sense, like hide the information about who was in which type of treatment. Gotcha. For a second there, I thought you were saying you got to hide from the principal investigators. Don't show them the data. They don't, I'm just kidding.
Well, and you even need to sort of, your goal is to kind of hide the treatment from the patients that they're getting as well. Right. So, how are you going to do that effectively when most people know what cognitive behavioral therapy is now, or they know they're just going in and talking to someone, so this just must be the control therapy group I'm in. But it gets very hard to hide whether you're in treatment or the placebo arm from everyone involved in the study.
Oh, and because the patient knows that they're participating in a study, that could also, that probably activates that thought process.
And Parker, you opened up a whole other Pandora's box with the whole people who are likely to participate in research trials. There's something different about them versus the regular population. So
right. So then the sample that we're getting might not be fully generalizable to all people, or at least American people, if it's an American study.
And I think the other thing that happens when you have, the way to deal with this issue is that the studies for the therapy treatments, instead of maybe, two really well done studies with positive findings on a medicine by different groups, that you feel really pretty good about that. Maybe for therapy studies, maybe you need 3 or 4 because we know they weren't able to, the subjects knew they were getting this new therapy type, or, the people who are delivering the therapy were, the people doing the study, the people delivering the therapy were also delivering a quote, talk therapy control. And so when the data is not as strong from a study, you just need more studies replicating it to have the same confidence.
Goodness. Yeah. Based on everything I know, I believe in the answer to this question, and it seems pretty obvious, but, you can't put them in the study without knowing that they're in the study, right?
Correct. Right. Or it's a human rights violation.
Right. There's no informed consent.
And our shady, we definitely have a shady dark past where
yes, we have a history of that,
especially to minority groups, and that we're still recovering from that. The final comment on all this is that, the problem with the intensity of doing these therapy studies is the main, we have the National Institutes of Mental Health to fund this research.
Mm-hmm.
We don't have drug companies to pour in the money needed to do these trials. So it's a very limited number of therapy trials, because you're not going to have, you're not going to have a large group with hundreds of millions of dollars saying, we've got the new greatest therapy.
Right.
Let's do all the studies and everything else to prove it.
People want a miracle pill that's going to solve all their problems.
And there's no patent you can do on a new therapy.
Right.
And so it's something to be very aware of about, we can be critical about the psychotherapy research, but we also need to understand it doesn't have the money or resources poured into it like medication trials do.
That is, I never thought about that, but that is, that's a pretty profound thought. All right. So just to move on to our last question here, how can a provider stay up to date on, the hottest new evidence-based therapies on the market? And how might they be able to incorporate these types of things into their practice? They see, for example, actually, we had, Julia Maestas of Walking Out Therapy as a guest podcast a few months ago, and she does walking therapy with her clients, and she had to kind of take a risk and just kind of try it out and get the methodology from somebody that she knew, if I recall correctly, who was doing a lot of this. So yeah, in that position, how do you stay up to date, and how do you incorporate these things?
Yeah, it's hopefully for every licensed clinician, there are these CME or continuing medical education requirements that you have to meet to keep your license. Hopefully you're spending some of that looking at journals that are published in your field, or going to an annual meeting where they might talk about new research. For me, my secret was that I give this talk on evidence-based treatments to different groups. And every time I'd give it, I'd say, hey, has anyone heard of anything new that wasn't included? And it's sort of a nice way to multiply the number of people you're asking about new treatments. But yeah, it is an issue with, if you're very busy with your business or practice, you may not have that time to be keeping up with all the latest and greatest current research. And it's another limitation to evidence-based medicine that, is a lot of places don't pay you for your time to stay up on best current practices. So it's up to you. And depending on what else is going on in your life, there may be times, and this has happened for me as well, of course, where you felt like, oh, I haven't been as up on the latest and greatest treatments. But I do like Google Scholar. There are other tools available that make it easier now than it was 15 years ago to stay up on the latest trends. But it is up to people to take that initiative. And there are as long as you take that initiative, there are lots of options for seeing what new treatments are coming.
Yeah, that is really interesting. It seems like running a mental health based practice, once you kind of get going, on the type of therapy that you do or the type of system that you use, it becomes very, and I'm talking about like EHR system, it becomes very hard to switch, how you do things midway through. And it feels like, it's always easiest when people are starting to, make the choice of, am I going to commit to this thing, and making that decision of, I specialize in this, I do this kind of thing, rather than, I guess, changing things up. But I guess to follow up on that thought then, we've talked about specialties before. Say somebody decides, hey, they are a therapist and they choose to, they want to specialize in this new therapy. I guess it's, I think we've already answered this in the episode that we did on this, but I mean, do you just try it? There's no formal training on I guess some things maybe you need to be licensed to do. Like ketamine assisted therapy, yes, you need to be like licensed for that. But like EMDR or like other types of things, like do you need to be licensed for doing some of these evidence-based therapies?
Yeah, no, it's a great question. And, there are, when you have your license, right? It's sort of, I have a physician and surgeon's license in the state of California. Theoretically, I could open an outpatient surgery center and, but I'm not, that's not what my training has been. So theoretically, if you learned how to do a therapy by reading about it and wanted to try it, you can go for it. What there are a lot of places though where you can do, for some of the therapies that have sound evidence, like mentalization-based therapy is a newer therapy that seems to be having pretty robust findings for lots of things. And so you can do these mentalization-based therapy courses and get certificates that sort of give you a little street credit that you've had some real training and know how to do the therapy. But that is not required to be able to do a different therapy.
Okay.
But there are trainings you can do on cognitive behavioral. There are all sorts of trainings that you could sort of go through and get the certificate to put on your wall but it is not a requirement. And if you're a therapist already, on some level, it's not that hard to, get a book on how to do the treatment written for therapists and just go for it.
That's interesting. It's making me think that, when you look at somebody's Psychology Today profile and you see all the different things that they can cover, it's really just their way of saying, like, I've worked with a patient that has struggled with this issue before, and then maybe they identify like a top 3 that they feel like the most confident with treating. Anyway, was looking at Psychology Today recently, so that was top of mind.
There you
go. All right, so let's move on to the mental health business moment. This has been really interesting. I'm excited to talk about the, prescriber version of this conversation next time. But let's dive into the mental health business moment. What's new this week?
Yeah, I think I'll jump back just because there was another insurance. I know we do a lot. Maybe it's been a while since we did some insurance topics, but
probably
we have probably not. But an insurer that we have that is not known for paying well and that we would not even bother trying to pursue going in network with. But we have a patient with this insurance, and the family was able to get the insurance company to reach out to us about a single case agreement. They initially offered, we'll give you 100% of what Medicare pays, which, it's nice that they reached out and made this offer, but the Medicare rates in general are, a third or half of what other insurance rates are for commercial insurance companies.
Yeah.
And so, I sort of wrote back and said, not acceptable. And I countered with, we will accept 200% of Medicare rates. And the person said they'd check with their supervisor, and then they wrote back saying, we will give you 125%. That is all we can do. That's our absolute highest. Take it or leave it. And I said, we'll leave it, but if you go to 150%, we'll do that because we do want to provide care for this kid that they can use their insurance for.
Right.
And they came back and said, okay. So they went from their sort of, this is the absolute maximum we could ever possibly do, take it or leave it, to, okay, we'll go another 25% higher. So it's just another message around, and it's ridiculous on many levels. Like, why do you have to do this, like,
negotiation?
You know, it's like gambling. Yeah. You know, it's like this sales. How much for your, I don't know, apples today? Like, is it a flea market? Anyway,
how to win friends and influence people.
So that was the moment of the week, and then we'll see where it goes from there. We've been collecting data in our EHR on claim denials, and it is by far and away statistically more likely to have problems with claims from these single case agreements.
Yeah.
So, which there's not really any reason why that should be the case. And so we'll see how it goes with submitting claims for this newest insurer, and I'm crossing my fingers that it will go smoothly.
Well, fingers crossed. All right, Tom, this has been fun. Thank you, dear listener, for joining us on this week's episode of the Sit and Stay podcast, brought to you by RipsyTech. I'm not sure why I'm bringing that energy to the intro and outro today, but if you have questions you'd like to submit to our audience Q&A or are interested in featuring as a guest in the show, shoot us an email at sitandstay@ripsytech.com. All right, Tom, this was fun. I'll see you later.
Thanks, Parker.
Thank you for tuning in to this week's episode of the Sit and Stay podcast. Until we meet again, we invite you to sit and stay with the ideas and stories shared today. Dive deeper into how RipsyTech can support your practice by visiting us at ripsytech.com.